So welcome everyone. Our webinar will be starting on the orthoptic examination of the child in just 1 minute. So it's 5:30 and this is the webinar on orthoptic examination of the child on behalf of IPOSC, wherever you're joining us from across the globe. We're honored to welcome all of you to this webinar. There are over 2,000 registrants for this webinar, and we look forward to a dynamic and engaging webinar. I'm Tamara Wignansky-Jaffe, IPOSC president, and I encourage you and your organizations to actively engage in the well-rounded activities of IPOSC and also the research initiatives. These efforts do have global significance and can support projects that align with your region's priorities. I'd like to thank all the speakers, the moderators, the American Academy for this wonderful platform, but I will also like to thank each and every one of you for the dedication and empathy for working in the pediatric ophthalmology community. So with no further delay, I'll pass it over to our moderators and introduce our first moderator, Seyhan.
Thanks, Tamara. Dear colleagues, good evening, good afternoon, or good morning, depending on wherever you are. I would like to welcome you all to the International Pediatric Ophthalmology and Strabismus Council and American Association of Certified Orthoptists joint webinar organized in collaboration with American Academy of Ophthalmology. So my name is Seyhan Özkan, and I am the IPOSC Training and Education Committee Chair. And this session is going to be moderated by me and Alex Christoff, who is the ACO past president. And may we have this opening slides, please? And so this session is, topic is chosen as orthoptic examination of the child, which is a very daily topic of our everyday practice, but full of challenges and controversies. So we have 6 distinguished speakers during this webinar, and at the end of each talk, we are going to have discussions, and please feel free to share your questions, to ask your questions in the Q&A box, and we are going to pick the questions up and try to ask your questions to the speakers as much as we can. And at the end of the whole webinar, if we have time, we may have another further discussion as well. So I would like to introduce the IPOSC speakers first. May we have the slide, please? And our first IPOSC speaker is David Guyton from Baltimore, USA. You all know him very well. So he's from Johns Hopkins Children's Center, and he's the Zanville Krieger Professor of Pediatric Ophthalmology at Zanville Krieger Children's Eye Center at the Wilmer Institute. And the next speaker is Deniz Somer from Ankara, Türkiye. She's a professor of ophthalmology, and she had worked in pediatric ophthalmology and strabismus department in Ankara Training and Research Hospital, where I have had the opportunity to work with her for a couple of years, and she is currently in private practice. And our third IPOSC speaker is Saurabh Jain from London, UK. You all know him. He's a professor of ophthalmology at UCL Medical School and a consultant ophthalmic surgeon at Royal Free London NHS Foundation Trust. So I'd like to give the word to our co-moderator, Alex Christoff. Yes, Alex, please.
Okay. Thank you, Dr. Özkan, and if I could have the orthoptic slides. Welcome, international colleagues. Thank you for joining us here today. We have three orthoptic colleagues today speaking to you. Sarah MacKinnon is an orthoptist at the Boston Children's Hospital. She is program director of the Boston Orthoptic Fellowship Program and just completed 9 years on the Journal of IPOSC editorial board. Next slide. Professor Ron Biernacki is assistant professor of clinical ophthalmology, Vanderbilt University Medical Center. He is also the program director at Vanderbilt Orthoptic Fellowship Program and an immediate past president of the AACO. Next slide. Kyle Arnoldi is assistant professor of clinical ophthalmology at the Ross Eye Institute Orthoptic Department. Professor Arnoldi is program director of the REI Orthoptic Fellowship Program, and she also is an immediate past president of the AACO. And without further ado, we'd like to start off with our first speaker. That's going to be Ms. MacKinnon, if we could have her slides up. All right, Sarah, thank you.
All right. Thank you so much for the invitation to speak today. I have no financial interest to disclose. So whether you use muscle stars or H's or another grading system, determining how well someone's eyes move can be easy. In cooperative patients with full or essentially full eye movements, it's often the quickest part of the sensory motor exam. Even in complex ocular motility patterns, a cooperative patient can make the ocular motility exam relatively easy, allowing you to look, and then look again, and then again if needed. This is not a luxury we have with most of our young patients, where sometimes a fleeting glance is all that they're going to give you. We often spend a lot of time with our trainees teaching them how to evaluate each muscle and how to determine what's over or underacting. But I think we assume that they'll learn tips and tricks for working with our youngest patients by spending time with us in clinic. I think it's important to talk about what to do when our patients arrive and maybe they're asleep. We can hope that if we wake them up, they'll be a willing participant, but that is not always the case, and they may wake up like this or walk into the exam like this. But my worst case scenario is this example. There's often some serious coaxing needed so that they'll unbury their face and you can catch a glimpse of their eyes. And maybe if they're lucky, you'll be able to perform the entire exam over the parent's shoulder. So if you look online or search on YouTube, there's a number of great videos teaching you how to assess eye movements. And the first instruction is to ask the patient to keep your head still and just move your eyes. That, of course, will not cut it for most pediatric patients. And while simply asking their parent to hold their head can work for some, you might also get a situation like this where they try to pull their heads away and you can't really see their eyes. Or they get really upset or just shut down completely and close their eyes. So I've put together a couple of tips and tricks to hopefully not just get you through your motility exam on a baby, but hopefully get some quality information too. So tip number 1 is patience makes perfect. Our young patients often need some time to settle into their exam, and rightly so, many are apprehensive of us and the entire experience. They often want to keep their eyes on you as the new person, and we can use their sideways looks to our advantage. I'll often just keep my distance and slowly move around them. If they're kind of pinned by sitting on their parent's lap in the chair, you can go behind your exam chair and it may force them into some extreme gazes. So in this photo from behind the chair, you can see the left eye dropping down in right gaze. Or in this other photo, the left eye not getting all the way out in left gaze. This, I'll admit, is a bit of an unusual situation where the patient would allow a patch, but did not want their head held at all. So I was able to not only check their versions from behind the chair, but ductions as well. Tip number 2 may seem obvious, but with children, we always want to try and make it into a game, and toys can help with that. While the expression one look, one toy can often be true, I can usually get a lot of mileage out of maybe 1 or 2 toys for the motility exam. You do have to read the room a little bit, but saying things like, keep your eyes on him, he might try to kiss your toes, and making some kissy noises, or watch out, he's going to eat your fingers, and saying yum yum will often do the job for most kids. And it goes without saying, but you definitely want to save your best toy for last. So if you have a light up unicorn wand, you don't want to pull that out and then try to go back to your little dolphin. So now, if for some reason your impressive unicorn magic wand doesn't work, you can try for our tip 3, which is our super, or rather supranuclear tests like doll's head. Here, the examiner holds the head and makes gentle but quick movements. You can look at both horizontal and vertical eye movements this way, but you do want to avoid with any neck issues. Next, we can try OKN if needed, where the drum is slowly rotated to elicit eye movements. And again, this can be done horizontally or vertically. Tip number 4 is to play the cards you were dealt. If your patient arrives in a car seat or stroller, don't take them out immediately. I always try at least a few elements of the exam in their car seat or stroller. As we talked about with tip 1, patients can be apprehensive in a new environment with new faces, but their car seat is fairly familiar and comfortable to them. And they're also belted in, and so they can be less wiggly, which always helps. And if it's not working, we just simply take them out. Now, this is a more rare situation. If your patient wears a helmet, try keeping it on. Craniofacial kids in particular can be sensitive about their heads being touched, but can be comfortable in their helmets and maybe not even realize that it's being held so you can do your motility exam. And if it's getting in the way, again, parents are happy to remove as well. And perhaps my favorite option is a bottle. While they're drinking, this often helps keep their head still so you can better assess their eye movements. Here we see our patient looking nicely at the toy, but turning her head and not wanting it to be held. But with her bottle, we're able to keep her centered and she'll follow with just her eyes. Similar in this photo, she's following it nicely, but with the bottle, we can keep her head centered. So this was her first set of photos, which was pretty good, I think, for a 1-year-old. But with the complexity of her eye movements, it was still a little hard to grade. So now with the bottle cropped out, it was much easier to see that we really weren't seeing any movement of the right eye at all. And it was essentially just sitting in abduction, no matter where she tried to look. And unfortunately, this is a fantastic motility exam, but I can't take any credit. It was all the bottle. So our last tip is photos, photos, photos. In case it hasn't been obvious, we take a lot of photos in our clinic. Photos can help to document anything you see on a patient exam. Things like head position can be great to document, but photos can also be helpful for the little ones. Fleeting glances can be studied if you're fast enough to capture them, and things you might question can be answered. For this patient, we were seeing pretty straight eyes when she was looking straight ahead, and she had congenital fibrosis of the extraocular muscles, so she could not elevate her eyes. But I thought when she was trying to look up, her eyes were crossing a little bit. And sure enough, we captured a photo showing a fairly significant crossing. I also thought her eyes might be drifting out when she was looking down, and again, we were able to capture that with a photo as well. So in addition to confirming things you see on versions, we can also use photos to confirm what we see on ductions. In these photos, you can see a big difference between how far the left eye can move out on ductions versus versions. Oops. We can also take photos or capture other elements of the motility exam, whether it's lid changes, globe retraction, those can all be documented with photos. And last, we're not restricted just to the photos we take on the exam. We can ask the families to provide what they have seen as well. They've often captured whichever eye misalignment they've seen on their phones and can produce that for you to see on the exam. But you can also ask them to show you or send you photos of them looking right or left or whatever gaze you might need. So to summarize, we covered 5 main tips and tricks. We can be patient with our patients while they settle in and use their apprehension and need to keep their eyes on us to our advantage by having them follow us around the room. Once they're comfortable, have some fun and make the motility exam a game. And you can always fall back on some super tests like OKN or doll's head if needed. You can use anything like car seats, strollers, or bottles to your advantage. And take all the photos. Document what you see or what you think you see, and then you can always go back and double check. And if all else fails, I hope your patient at least cries with their eye open, and that way you can still complete your ocular motility exam. Thank you.
All right, thank you, Sarah. I think we all share the challenge that we face in examining these children. So at this point in time, we're going to open it up to the Q&A box down below. Type your questions in there. And as I give you time to go ahead and do that, I guess, Sarah, I'm going to start off with one if you don't mind. When you call those patients in, these young pre-verbal kids into the exam room, do you put them in the chair right away, or do you let them sit with mom or dad in the side chairs while you're doing the HPI? How do you start the exam?
Yeah, it depends. If they're being carried in by their parent, I'll often direct the parent to the chair just so then it's not an abrupt change later. But if they're, toddling around, we might let them play and get comfortable before we try and move them over into the chair. So it's a little bit situation specific.
Makes sense. And
Sarah, so thank you for this excellent presentation. So I'd like to ask you for, especially in infantile esotropia, one of the basic challenges is when they have crossed eyes, the difficulty of evaluating the inferior oblique overaction, the elevation on adduction, as they have crossed eyes. So you can, check the abduction while closing and so on. But it is a challenge to observe the overacting inferior oblique. Could you tell us your tricks to evaluate those factors in infantile esotropes with large deviations and crossed eyes?
Yeah, like you say, ductions are always important. You're trying to do inferior oblique overaction. I do find photos still very helpful. Trying to keep their head centered, whatever method, if it's with the bottle, if it's with parents holding it and trying to capture some photos, it gives you some time to kind of carefully look and see the position of one eye relative to the other. Sometimes when we're trying to get them to look, they're not sustaining that look for us. So it's a little bit harder, I find, to judge.
All right, we've got a few questions in the chat box, and we'll just take these one at a time. The first one is Sarah, how do you check kids with developmental delay?
Again, we try and meet them where they're kind of at. So if they are, there's all different levels of developmental delay, but kind of trying to gear the exam to what they can accomplish and kind of how their functional level is usually kind of where we start.
And we have one more question. And which camera do you use, flash or no flash?
Definitely, we try
do you
and
have
use
any preference?
Yeah, we use SLR photography so that we can also rely on the corneal light reflexes for looking at their strabismus. So definitely with the flash.
So this is a very good point.
Another question is, do you ever perform doll's head maneuver by having the parent spin on the chair with the child in their lap? Wow.
I learned about it, but to be honest, I've not done it myself.
There is the spin VOR that's not the subject of this talk, but we can do that where you grab the baby and spin, but that's, yeah.
Yeah, I haven't done it myself, but I do remember learning about it.
All right, there's another question. How do you place photos while you examine the baby? Oh, you use another help. I'm not sure if I understand that. Maybe it's like, how are you capturing the photos and where are you putting them? Are you uploading them into the EMR, or maybe that's what the question is?
Yeah, so we take especially with babies, I take a lot of photos because you don't know what you're going to be throwing out after. So we do try and take as many as we can, hoping to capture whatever it is we're seeing and then go back through and delete some of them out. We have a pretty intricate system that we've developed where I work, where there's a whole process for both downloading and storing original, and then we format the photos into those grids you see. And once they're formatted, then they're uploaded into the medical record system. But we do keep the formatted and the original photos, which are helpful when you're asked to do a webinar like this.
And we have one more question in Q&A box, and this is on the how do you have any specific pearls for examining autistic childs? You know, they usually look at your mouth instead of your eyes, and what can you tell us about those?
Yeah, so we've done a couple of different things for working with autistic children. We also try and explain the exam step by step in advance before we do it as well. We've created some what to expect when you come to the eye clinic, both from a general sense, and we've also created one geared for our autistic patients, so it walks them through each step of the exam. I often ask the family what they like, especially when it comes to the motility exam, if they have their own favorite toy, if they like lights, if they'll, like sound, and they'll follow by sound. So we'll just kind of try it based on what that child prefers.
Thank you.
This is a question from some orthoptic students in Portugal. Can you explain the logic of the doll's head maneuver? Not very commonly done there, apparently.
Okay, well, I can actually, if it would be helpful, I can send the photo or the paper that I referenced. So there's a whole pathway involved that I don't know if we have time to go through all of that today, but I'd be happy if it's in the chat, I can actually maybe link to the paper that goes through the whole process.
It is in the chat.
Okay, great. Yeah, I'll do that once we're finished here. I'll try and link that. And
if we have time for another one, I'm not familiar with this term, but how common do you use the Catford drum? I don't know what Catford, C-A-T-F-O-R-D. I'm not familiar with that.
Yeah, so it's similar to the Özkan drum. We do not have one where I work now, so I do not use it at all. But yeah, I am familiar with it. It's a similar concept to the Özkan drum.
I think we need to go on the next speaker. Alex, please, could you introduce?
Very good. Okay. Our next speaker is Professor Ron Biernacki from Vanderbilt University. And if we could share Ron's slides.
You have it, Alex?
I see it. Very good.
Okay, well, thank you for the kind invitation and the kind, I'm going to be speaking on the evaluation of binocularity. I'll be speaking from Nashville, Tennessee, so it's still morning here. I have no financial disclosures. So before we look at the test, let's look at the development. There are both anatomical and physiological factors, conditions that are required for the development of binocular vision. So at birth, the fixation is poorly developed with the child only random, non-conjugate, and aimless ocular movements. And then about 2 to 3 weeks, they can follow light monocularly. And then beginning around 6 weeks, they'll follow light binocularly. Convergence is absent at birth. It starts to develop about 1 month of age, and it's well established by 6 months. So what are the advantages of binocularity? It allows us to appreciate single vision, stereopsis, and to expand our field of vision. There are 2 types of fusion that we use: sensory fusion, which includes central and peripheral fusion, and motor fusion, which uses our vergence system to allow our eyes to align. Normal binocular vision is when all the points on the retina have an inherent visual direction. And then all those points make up the horopter, or horizon of vision. So the objects localized on a plane lying in front or behind the horopter are seen as having depth. In Pannon's fusional area, there's a limited area that surrounds the horopter curve where the visual system can fuse 2 disparate images made up of horizontal disparate points, because the vertical displacement produces no stereo effect. And then Panem's area expands and contracts depending on the size, sharpness, and speed of the stimuli. I think it's best to demonstrate Panem's area by using the physiological diplopia to elicit crossed or uncrossed diplopia. So when you look at the distant object, the near object will have crossed diplopia by using the temporal retina. And then if you concentrate on the near object, that distant object will demonstrate uncrossed diplopia by stimulating the nasal retina. But our visual system is quick to adapt and to suppress an image to prevent double vision or confusion. So stereopsis measures how well your eyes work together to perceive depth and three-dimensional images. It's measured in seconds of arc, which defines the separation of images. And the two common type of stereo tests are the Titmus test, excuse me, and the Randot. So the Titmus fly is considered to have 300 seconds of arc, and then the smallest circle, the ninth circle, has 40 seconds of arc. Now, stereoscopic acuity is the smallest binocular disparity that can be detected. However, there are no really standardized clinical stereoscopic tests, but a threshold of 15 to 30 is regarded as excellent. And the Randot test comes down to 20 seconds. So stereopsis is essential for depth perception, but it's not the only means for spatial orientation. There are various monocular clues which helps with depth, which I have listed here. I'm not going to go through all of them, but the size, an aerial perspective, shading, relative velocity, and then motion parallax. So let's look at some of the binocular testing that we do. All the binocular tests are aimed at assessing the presence or absence of normal or abnormal retinal correspondence, suppression, simultaneous perception, fusional amplitudes, and stereopsis. And before any test is undertaken, it's also essential to assess the visual acuity, the fixation of the strabismic eye, the direction and size of deviation. So we talked a little bit about NRC. What is ARC? So abnormal retinal correspondence is when the retinal correspondence in which the fovea of one eye is associated with the pseudofovea area of the other eye to give rise to a perception of a single object. And it's usually seen when the angle of strabismus is small. So let's look at some of these testing. These are listed from the least dissociating to the most. And we'll start with the Bagolini lens. So this is the least dissociating test. The patient has to be old enough to be able to draw or at least explain their findings. If a cover test reveals no shift in the fixation essential, the patient has NRC, which is an A. A single line will represent suppression. And then if a cover test reveals a shift, you can have harmonious ARC. And then foveal suppression scotoma with peripheral fusion, which you see in monofixation syndrome. The 4-base out test is used to detect a small central scotoma. And according to Hering's law, the movement of the fellow eye will move outward simultaneously and symmetrically, which is our version, when the eye under the prism refixates, and then will perform a slow fusional movement, adduction, in the opposite direction to correct the image displacement. However, if there's a central scotoma has impaired the foveal function, the second phase, the fusional movement, does not occur, and sometimes the eye will actually remain slightly turned out. Our red filter test, you want to place the red filter in front of the fixing eye while the patient is looking at a small light source. And it's used to detect suppression, retinal correspondence in B and C, and then crossed or uncrossed diplopia. The Worth 4 dot is probably the most common test that we use in the clinic. It's more dissociating than the Bagolini. If the patient sees all 4 dots, you could have normal binocular response with no manifest fast deviation. You have NRC, or you could have a harmonious ARC with manifest strabismus. If they report 5 dots, you have diplopic with uncrossed or with ESO, in E1 and crossed with an XT in E2. And again, you could have a monofixation syndrome, suppression in the distance, and fusion at near. When there's three types or grades of binocularity, simultaneous macular perception, fusion, and then stereopsis. And all three of these slides are color-coded when we use our synoptophore. There's also a white slide, which can measure torsion, which is seen here. So the red slides, the green slides, and yellow slides, and a white slide. ARC is measured as an objective angle. That's what we see as the examiner. So in this case, say it was an ET of 30. The subjective angle is which the patient then sees or fuses those images. So let's say an ET of 20, and the angle anomaly is the difference between those two. So in this particular case, it would be 10. Abdominal retinal correspondence is also classified in three forms. You have harmonious, and that's when the angle of anomaly is equal to the objective angle of deviation. So this indicates that the ARC fully corresponds to the strabismus. You have unharmonious, where the angle of anomaly is less than the objective angle, and paradoxical, when the angle of anomaly is greater than the objective angle of deviation. And lastly, the after image test, which is highly dissociating. You use a flash to produce a vertical after image in one eye and a horizontal image in the other, and the gaps respond to the direction of each fovea. We also have abnormal binocularity or binocular vision, which are visual confusion, retinal rivalry, and diplopia. So visual confusion is a simultaneous perception of the two different images. They're superimposed on each other. This is rare in children because the brain will suppress, and it's rare in adults because they are more likely to have diplopia. Retinal rivalry, corresponding areas of the two retinas are stimulated by non-fusible objects, may differ in color, contrast, and contour, a visual phenomenon where the brain struggles to perceive two different images presented simultaneously. And this leads to perception of only one image at a time when the two image alternating dominance over time. And then diplopia, which we all see certainly in our adult clinics, it's the awareness of seeing two similar images. And it's important to differentiate between the monocular and binocular diplopia. Usually if a patient comes in and they don't say they can see two images, really investigate monocular diplopia. And then I'm going to leave you with where do bad rainbows go? To PRISM. It's a light sentence, but it gives time to reflect. These are my references. Thank you.
All right. Thank you, Professor Biernacki. Sensory adaptation is perhaps one of the hardest things to teach orthoptic students and residents and fellows. So thank you for helping us clarify these complex problems. There are already a few questions in the chat box, and I'll start with one. Typically, with what size and type of tropia does ARC occur?
I'm sorry, can you repeat that, Alex? What size?
Yeah, sure. Typically, with what size and type of tropia does ARC occur? I mean, is it more common in ET, XT?
Yeah, usually ET, and there's small angles.
Okay.
Less. Yeah, I mean, you see that in the monofixation where it's anonymous, a little bit outside the monofixation range.
There's another question here. Worth 4-dot test. Can you explain if someone sees two red and two at a time, or three green, or I guess they're asking for the response. Yeah,
I think it's alternating suppression. If they're seeing five and I think that's what I understand, where they're seeing two and then three and they're doing it quickly.
Yeah. I have a question for you. In some of the older, long-standing decompensated XT patients, I find when they come in for the first time, and there's no previous history, no documentation, and you ask them about symptoms. Once you've established the long-standing nature, you're probably not expecting them necessarily to have diplopia, but they certainly can. But you ask them about double vision, and there's this big pause, and they're not quite sure what to say. And then you finally find out that they tell you about confusion, panoramic, where they're seeing actually two different images in the same visual space. Do you have a way of putting that in your Q&A, like your HPI, when you see these patients, you routinely ask, are you seeing double or some other kind of confusing thing to help them?
I always do. So I usually have the patient sit across from me and I'll tell them we're just going to chat for a minute, and I see that you're referred here for a double vision. First of all, I'll always say, can you explain the double vision to me? Is it horizontal? Is it vertical? And even though they're smart people, sometimes I'll even ask them with my hand, are you seeing it this way or this way? And then I ask, does it go away if you cover your right eye? And does it then go away if you occlude your left eye? Because oftentimes they'll say, oh, it goes away if I close my right eye, but they don't, then cover the left eye. So you can't really tell if it's monocular in the left eye. What I find anecdotally is usually patients who come in and they don't really know if they're seeing double. I mean, almost everybody comes in and says, man, I have to wear a patch or I have to cover an eye to get rid of that double vision. I find that if people come in and they say, I really don't know, then I really want to investigate monocular diplopia. I'll ask them if it's, I use the pinhole a lot too, when they complain of monocular diplopia. Is it a refractive error? And oftentimes, just by the pinhole alone, you kind of narrow it down.
This is a good question because it comes up all the time. Have you found that patients with ARC, anomalous retinal correspondence, experience double vision after strabismus surgery?
It's a good question.
It is.
I don't think so.
And I guess maybe the question is prolonged post-op diplopia.
Because I think we do that. That's the purpose of these tests ahead of time, to negate that.
Do you think there are any high risk?
To pick up the ARC before they have surgery and they come back and then we find out they have the ARC.
Okay.
I think we need to skip to the next speaker,
all right.
Alex.
Thank you. Thank you. Appreciate that. Okay. Thanks, Ron.
Okay, so our next speaker is David Guyton, and he is the mentor of mentors, and he's going to speak on dynamic retinoscopy to assess accommodation, especially in Down syndrome and neurological problems. So we look forward to hearing his talk. Yes, David.
Okay, thanks very much, Özkan. I appreciate the invitation to participate. My talk is on dynamic retinoscopy. Now, that we use that to assess accommodation, especially in Down syndrome and in various neurologic disorders. I have no relevant financial interest to disclose. The objectives of the talk are first to understand the principle behind dynamic retinoscopy, to encourage using dynamic retinoscopy for the assessment of accommodation, and to understand the important application of dynamic retinoscopy to the management of Down syndrome patients and various neurologic conditions. Now, the retinoscope is the tool that we use most objectively to refract patients and also to assess accommodation, as we'll see shortly. The retinoscope was devised in France in the later part of the 1800s, and this was the first retinoscope. It was a plano mirror, a flat mirror with a hole in the center. And here is Abraham Lincoln being actually retinoscoped with a plano mirror retinoscope with a light source beside his head, a candle. We've come a long way since then. Several terms were coined to describe this process: skiascopy in Europe and retinoscopy in the United States, but neither one is appropriate, but those names stuck. In the early 1900s, Wolf in Germany came up with the first self-luminous spot retinoscope by putting the light source in the handle of the retinoscope. And then in 1922, Jack Copeland, a young optometry student, was playing with one of Wolf's self-luminous spot retinoscopes and dropped it on the floor while it was still on. The filament broke, but then when he picked it up, somehow the filament re-welded itself into a horizontal position, creating the first streak retinoscope. Jack Copeland actually recognized the value of that and actually patented the first streak retinoscope in 1925, 100 years ago this year. Most of his writings are buried in his instruction manuals for his retinoscopes, which he used to teach large basic science courses across the United States and to travel to individual programs to teach 5 or 6 residents at a time streak retinoscopy. I had his course actually in 1969, more as a medical student, and he died in 1973, so I overlapped him a couple of years. Now, we're not interested in where the light is coming to focus relative to the retina in retinoscopy, such as in emmetropy. We bring parallel rays of light in from the distance, coming to focus on the retina. And in myopia, the focus is in front of the retina, and in hyperopia behind the retina. But we're not interested in that in retinoscopy. In retinoscopy, we turn the light around. We start with a spot of light on the retina and see where the rays of light come to focus out in space, showing us where the patient is focused. If there's no accommodation happening, this shows us the far point. And the far point of an emmetropic eye is at infinity. For a myopic eye is between the eye and infinity. And with the hyperopic eye, the far point is actually a virtual one beyond infinity, which sneaks up on us from behind. Okay, so the retinoscope has often been called a far point finder, because when you move the peephole of the retinoscope to where the patient is focused, or you move that point of focus to the peephole, this very critical neutralization reflex is seen, which tells us that's where the patient is looking. Let's see how that works. With the old Copeland streak retinoscope, you had to hold the sleeve up to do this maneuver. With the newer ones, with the sleeve, you usually hold it down because it was designed differently slightly. And if the patient is looking beyond the retinoscope, you're the examiner, you're off to the right, and you're looking at the patient's eye, which is the red eye in the center. If the patient is looking beyond the retinoscope, then as you sweep the band of light across the pupil, what happens is the very first rays of light that get into the peephole came from the top of the patient's pupil, from the top of the patient's pupil. So the examiner sees this band of light appearing in the top of the patient's pupil. And as the band of light on the eye is swept down, you'll see this band of light in the pupil, the retinoscopic reflex, move in this same direction in this case, which we call with movement. We all know that, with movement like that. And that means the person is looking beyond the retinoscope, beyond our eye. If the person, though, is focused in front of the retinoscope, like things cross over there at the so-called far point if there's no accommodation, and everything is backwards. Now the first rays of light that get into the pupil when you sweep the light across the pupil came from the bottom of the pupil instead. And so the examiner sees a band of light appear at the bottom of the pupil. And then as you sweep down, that band of light, the retinoscopic reflex, actually moves in the opposite direction, what we call against movement, telling us the person's looking in front of the peephole. But if the person is looking and focused at the distance of the peephole exactly down at the bottom, then all the rays of light get into the peephole at once as you sweep the band of light across the pupil. And so it comes up, all the rays of light get in there at once, and the pupil just lights up all of a sudden, like this, like that. And as you sweep the light across the pupil, you see the light, the pupil turn on and turn off, turn off, turn on, turn off, turn on. And that's the neutralization endpoint that we're using, especially with dynamic retinoscopy. So what do we do with dynamic retinoscopy? What's involved? We provide a distant accommodative target beyond our head, off from the far wall, and also hold an accommodative target beneath the peephole of our retinoscope. We'll do that in the distance, asking the person to look at the far target and then look up close and read the letters up close, as you see here. Okay, and we compare what happens to the retinoscopic reflex when the patient does that. So ordinarily, you put the distance correction in place if it's convenient, and you're able to do that, and usually occlude the other eye because you're looking at monocular effects here, and sit close to the patient, closer than usual, so you can see the reflexes better. 10 to 15 inches away is where I sit. The distant target is seen past your ear. Ask the patient to look at that. And then you sweep the streak across the pupil. And you should see, if the person's looking at that far target, you should see strong with movement. Sometimes you need to rotate the sleeve a little bit if there's astigmatism to get the strongest with movement. And then, so what you should see then when the person is looking at that distant target, you should see strong with movement. The reflex moves in the same direction as the intercept or the band of light that you're sweeping across the pupil, strong with movement. So then you ask the patient to read the near letters that you're holding just beneath the peephole of the retinoscope. If the patient is too young for letters, put something there that attracts the child's attention. And you observe the dynamic change in the with movement to neutralization if accommodation is normal. It takes about a half a second. You see the reflex, the with movement, go to against movement. Not against movement, but the neutralization reflex, the pupil fill with light. So here you are looking up close. And if you still, this is what you saw of the patient looking in the distance. If you look up close at it and the patient reads the letters beneath the peephole of the retinoscope, you should see that reflex with movement disappear. And you get the neutralization reflex if the patient is fully accommodating with showing normal accommodation. But if there is still with movement, when the patient is looking at an accommodative target right under the peephole of the retinoscope, then you have found hypoaccommodation, which is the abnormality we're looking for in a dynamic retinoscopy. What are the usual causes of bilateral hypoaccommodation in children? Well, bilateral high hyperopia. Sometimes the hyperopia is so high the patients don't even bother to accommodate, to neutralize. Convergence insufficiency is sometimes accompanied by accommodative insufficiency. And then with various neurologic causes, such as bilateral third nerve palsy, of course, that's a rare cause, but certainly that's where you don't have accommodation at all as well. But then look at Down syndrome. Now, we discovered several decades ago that 80% of the patients with Down syndrome weren't accommodating at all when we did dynamic retinoscopy. That was quite surprising to us. I'd noted a lack of accommodation in the early 1980s, I started prescribing plus 2.5 to 3 diopter bifocals, high line bifocals, because I was concerned they may be developing bilateral deprivation amblyopia. That's what I wanted to prevent. And then I kept doing that from 1983 to 2007. We had accumulated 86 patients. By 2013, we had obtained follow-up on about 57 of the 86 patients. 27 were those with bifocals that I had prescribed, and 30 with single vision wear, which my colleagues had prescribed because they didn't believe in me. And we asked, were they still wearing glasses? And this average follow-up of 4.25 years after being prescribed either the bifocals or the single vision glasses. So we wanted to know, were they still wearing glasses? And in the bifocal group, 89% of these children with Down syndrome patients were still wearing their glasses. In the single vision group, only 50%. So something we were doing with the bifocals was working. They were actually wearing glasses. It may have been changed by that time, but they were still wearing the glasses. The others were not. We published that study in the Journal of IPOSC in 2014. And we've come to actually, because such a high percentage of these patients don't accommodate and the remaining ones don't accommodate that well, we are recommending now that you really should give high-line bifocals to every child with Down syndrome patients, even those that have able to accommodate. Some seem to do well with these glasses. And the parents state, gosh, that they do better as well. I don't have a good study on that, but several studies have come out showing performance improvement, also with bifocals, particularly in England. I think Woodhouse is the main promoter of that. The studies in England are looking at that. So I would recommend high-line bifocals, most all patients with Down syndrome patients, guided by, if you wish, and I hope you will, using dynamic retinoscopy. Thanks very much.
Thanks, David, for this excellent talk. So while looking for the Q&A, and I would like to ask you a couple of questions. So first of all, thank you for bringing out this dynamic retinoscopy method. Well, I must say that it is my basic examination method for those kids. And what I want to ask is, when you mentioned that you prefer to make it by occluding one eye. However, well, I would like to learn your opinion. I only occlude if the patient has some squint. Otherwise, I do not occlude specifically in order to compare the accommodation level in both eyes, which is very helpful, especially in monofixations and so on, and to assess the amblyogenic factors and so on. So I would like to learn your opinion on that.
Oh, I certainly agree that I do it binocularly as well, particularly in third nerve palsy patients when I want to judge the amount of accommodation insufficiency. So I agree. I do both, but if I want to look at one eye at a time, then I do occlude it. But it gets hard to hold the things in front and also to hold the refractive correction in front. So you sometimes need some help in holding the equipment up to do that. Thank you.
Thank you. And my other question was, I would like to learn your experience about autism spectrum disorder children, about accommodation insufficiency as we see in Down syndrome.
Yes. We've looked at autism patients quite interestingly, and I mean, yes, they don't fixate. They don't like to look at people's eyes. Now we've studied that. We've actually wrote a paper on that. It turns out that there's a characteristic way that people look at each other. If one person switches fixation one eye to the other person will switch as well. We learn to do that. Looking in the mirror, we do that, and that's the way normally people do. But these kids don't do that. And these days, they are given puppies at an early age to teach them to look in eyes, because it turns out that puppies, dogs do the same thing. If you look at switch your fixation one eye to the other, the dog will follow that, just like human beings. And that's had a lot of success recently in helping autistic young children learn to look properly at people's eyes. Fascinating.
There's a couple.
And there is a question in. Sorry, Alex, please
No,
go on.
ahead. Go ahead. No, go ahead.
Well, in Q&A box, there's a question, and they ask whether what is the age that you start bifocals in Down syndrome?
I will start them whenever I see them at first, even age 1 or so. You rarely see them that early, but I've started at age 1, and gosh, it's amazing to often see the parents come back and say the child actually does wear the glasses. Clearly, they must be helping. So I can start at an early age if you can keep the child on, usually with a band to keep them on the face. But they usually, in my experience, work.
And there is one more question. Are there any tips for seeing the reflex during accommodation in those who had small pupils?
I haven't had that much of a problem looking at the presence or absence of the neutralization reflex in small pupils. It's hard to really refract clearly in small pupils because you don't see the full extent of the reflex. But if you compare the strong width movement when looking in the distance with the neutralization up close, that's been pretty easy to see, even with small pupils.
I think we have time for one more question. There's an interesting question. Is dynamic retinoscopy helpful in diagnosing accommodation spasms? What do you think on that? Yeah.
Well, these patients with accommodative spasm, they're going to measure as being myopic, usually quite myopic, and stably myopic. They don't switch back and forth that often. They'll often they don't go back and forth very, very much. So I have not really needed dynamic retinoscopy because they won't relax that accommodation, look in the distance to compare distance to near. So that has not been very helpful there.
Well, I said the last, but I'd like to ask one more in the Q&A box. There are lots of questions, and people ask whether you can wean off the bifocals in Down syndrome patients, or is it something forever?
I have
or
not.
Can you switch to the progressive lenses when they become older?
I'm sure you could switch to the progressive lenses. I have not, though, seen the accommodation improve in patients with Down syndrome when I've seen them at successive times. It's still there. They still use the bifocals. They still need the bifocals in my experience.
So,
I think we're good.
actually, there are many other questions, but maybe we can discuss at the end. So Thank you very much for this very excellent presentation. Alex, do you have anything to say? And then don't. If not, we have to switch to the next speaker. Thank you so much.
Thank you.
Thank you, Dr. Guyton. All right, our next speaker is Professor Kyle Arnoldi from the Ross Eye and Ear Institute. If we could have her slides, please.
Thank you for including me in this webinar. When the organizers asked me to speak on monofixation, I thought I might approach it from the viewpoint of outcomes. So what that means is that most of my talk is going to be concentrating on secondary monofixation. I have no financial interest to disclose. So parents, patients, ophthalmologists, surgeons, and orthoptists would all agree there are three broad areas that we look for when we're judging success. The eyes appear straight, there's no double vision, and the result is lasting. But there's a lot of gray area in here. Straight is somewhat subjective. No double vision could mean suppression or fusion, and we don't seem to be able to agree on what long-term means. Where these three broad goals intersect is the monofixation syndrome. Now, we've known about the special qualities of small angle esotropia in particular for more than 75 years, but Marshall Parks is the one who is credited with consolidating that theory under the term monofixation syndrome in his 1969 AOS thesis. And since that time, alignment within 8 prism diopters of ortho has been considered the global standard for success. At its heart, monofixation is a disorder of binocular vision, featuring foveal suppression, peripheral sensory fusion, fusional vergence amplitudes or motor fusion, and gross stereopsis. But as we all know, monofixation, especially secondary monofixation, is very often associated with a small angle strabismus, usually an esotropia. And the esotropic monofixation syndrome is special because the convergent deviation is probably the default position in children when bifixation isn't possible, and it confers a functional advantage more so than XTs or hypers in monofixation. Now, over many decades of seeing patients and performing some research studies and doing a lot of reading and studying, my personal definition of monofixation has softened up a bit. It's a little bit less pure or strict than it was originally described. I still go with an 8 prism diopters of ortho as my alignment. The foveal suppression scotoma is key, but I look for any evidence of peripheral fusion. Usually this means sensory fusion. That is the easiest for the brain to achieve. But I also hope to find some motor fusion because I believe that this is probably the key to a lasting result. Now, you might look at my criteria and say, Kyle, what about the stereopsis? Well, back when Dr. Parks did his original study, the Titmus test was used to detect the presence of stereopsis. Now, this is still the most widely used stereo test around the world. The majority of his cases in the original study only saw the fly. There were some who had much better stereo than that, but most of them were positive for the fly. Now, we're all aware that the Titmus circles and animals tests are deeply flawed, but the fly is even worse. And so I question the presence of gross stereopsis in most of the patients that were in the original study. But frankly, the presence of stereopsis does not prevent decompensation. Certainly, it's a sign of a very fine surgical result in a very small angle, but it doesn't really protect the patient going forward. In fact, since that original study, we've learned a lot more about the presence of binocular vision in manifest strabismus. We now know that the manifest deviation limit that is still consistent with peripheral sensory fusion is up to 25 prism diopters in esotropes, less than that for exotropes, and even less than that for vertical monofixation. We haven't yet experimentally defined the limit of a manifest deviation that would allow motor fusion, but undoubtedly it's going to be less than that 25. But here's the key. It appears that the manifest deviation limit for true stereopsis, as measured by the Frisbee test, is only 4 prism diopters. So I think it's possible that expecting even gross stereopsis in our secondary monofixators is maybe a little bit too ambitious. So let's look again at our criteria for success. What is success? I think that depends on who you ask and at what point in the follow-up you are asking the question. So eyes appear straight. There are some recent publications, surgical outcomes, in which misalignments up to 15 prism diopters are considered successful. Suppression, often, as I said, considered just as good as fusion, and lasting results, we simply cannot agree on what is considered long-term, with many studies reporting outcomes at only 12 months. So let's take a look at each of these three broad criteria, beginning with the residual misalignment that is considered acceptable and successful. Where did that number come from? Well, there have been a couple of studies that have tried to determine what a lay person might consider to be a wandering eye. So by looking at photographs of patients with strabismus, we determine what is the smallest manifest angle that someone who is not working in the field would recognize as a misalignment. And the study from Larson and co-workers in 2003 showed that to be about 12.5 prism diopters, with a little bit larger for hypotropias. A more recent study in 2016 showed that the alignment threshold that allows a 70% positive detection rate by lay observers was 20 prism diopters or more for ESOs and 15 or more for exos. So it's true that within 12 to 15 prism diopters of orthophoria or orthotropia might look normal to a parent or a patient, but probably not to the ophthalmologist or the orthoptist. What about suppression being just as good as fusion? I would argue that that's not the case. Suppression prevents disparity information from reaching higher cortical processing areas. And that's a problem because suppression then will block the fusional vergence signal that can eventually lead to loss of alignment control. So even if the patient has motor fusion amplitudes sufficient to neutralize that manifest deviation, those amplitudes will not be activated because suppression is blocking disparity. Loss of control is going to cause deepening of the suppression that's already there and could lead to post-surgical drift and, in this case, decompensation of monofixation. Now, of course, disparity information is critical for the appreciation of stereopsis, but we can't forget about its role in motor fusion. Over time, with deterioration, these patients can lose whatever gross stereopsis they might have had. Finally, let's look at what we consider to be long-term. Now, Parks was pretty adamant that he considered lifetime stability to be a major feature of monofixation syndrome. However, recent reports have shown decompensation in monofixation in up to 31% of cases. Now, rarely this decompensation occurs within a year of achieving monofixation status. Usually that deterioration happens much later, up to 20 years later, with the risk increasing dramatically after age 40 years. There are some factors that have been statistically associated with stability. These include primary monofixation rather than secondary. When strabismus is present and esotropia is going to be more stable. Smaller angles of manifest strabismus, even smaller than 8. If you can manage 4 prism diopters or less, you're more likely to be stable over time. But this is where I think the key is. The presence of fusional vergence is the only type of binocular vision that has been statistically associated with stability over time. The factors that increase the risk of deterioration include a monofixation with an XT or hyper angle, an older age at the time in which monofixation is achieved, the presence of oblique dysfunction or pattern strabismus, amblyopia or some change in vision, especially if that change in vision is in the dominant eye, and just aging. We do tend to lose our motor fusion amplitudes gradually with age. It's perfectly normal. And because most monofixators are esotropes, divergence, the loss of divergence is going to be more marked than, or more noticeable than the loss of convergence, and these deviations will decompensate. So to conclude, as we know, monofixation is a binocular vision anomaly that is characterized by a suppression scotoma that is limited to the fovea with peripheral fusion. If strabismus is associated with the monofixation, the smaller the angle, the better. Gross stereopsis is possible in secondary monofixation, but not as common, I think, as we might have been led to believe, and does not contribute significantly to stability. Fusional vergence, on the other hand, is likely to provide the best fusion lock for stability. And decompensation after 12 months of stability is not uncommon, and the risk increases significantly with age. I believe this is something that we need to discuss with the parents of our patients, even after a successful surgical result. Thank you.
All right, Professor Arnoldi, fantastic. You know, Kyle, you always give us so much to think about and to apply to our clinics the next day. While we're waiting for the questions to come in, I know one or two are already there. I am so happy to hear you dispel the sort of gross stereopsis thing. I thought I was the only one that was teaching it differently in the programs, but that's great to hear. And I think that's going to catch on. And the other thing I wanted to say, and this addressed to the surgeons out there, a very interesting comment about, you know, about the role of suppression in interfering with fusional vergence. And so my question is, in terms of when we do preoperative evaluations, we're predicting sensory outcomes. You know, they're going to be fine. They're not going to be fine. Do you think then that surgeons should target like 0, like perfect for those patients instead of leaving like, let's say, XTs as a little ET because they're going to drift out because maybe they don't have any? Do you think there's some role of being more specific in strabismus surgery versus getting them close?
Not being a surgeon, I can still imagine that it is very difficult to, I think we should always be targeting for 0, because I think it's difficult to actually achieve 0, or at least achieve 0 in a lasting result. Even with the best surgeon and the perfectly planned surgery, because there are so many other factors, especially in the patients we're talking about today. The nature of childhood onset or infantile onset strabismus is supranuclear. So we are probably not changing any wiring in there. And, you know, the brain may be thinking, well, it's normal for the eyes to be in this position, and we should be expecting drift over time. So I think targeting for 0 is really important. I thought you might be going to ask me about measuring fusion amplitudes in someone who's really young. I was kind of hoping you would go there. It is, you know, I think, so I'm going to answer a question that maybe wasn't posed, but I do think it's important information. I didn't include it because of time constraints. I think many people, when they go to measure fusional amplitudes, they are looking for a response from the patient in the form of, oh, I see double, which of course is not going to happen when you have a child, even if it's an older child, okay, because a lot of them are going to be suppressing. I don't do that. I look at the eye position. I determine when they break fusion by the sudden appearance of a much larger manifest deviation. And if you go by that, you might be able to measure amplitudes even in a young child. The suppression scotoma, of course, gets in the way. So even when the older child breaks fusion, they're probably not going to tell you they see double. So watch the eyes when you're testing motor fusion.
Thank you.
And thank you, Kyle. This was a great presentation. So your topic was mostly on the secondary monofixation, but my question is going to be on the primary ones, because we know it is, for many people, it is the most challenging and mostly missed diagnosis. And I have seen many patients who had MRI before having a 4-dot test. 4-prism test. And my question is, you know that 4-prism diopter test in a small child, it is almost impossible to see. Could you tell us your tricks how to get the result of the so-called 4-prism diopters test? Do you use higher prisms, and how do you handle that?
I still stick with the 4 because if I go higher than that, I am concerned that I'm going to be throwing the retinal image off of the fovea. And so I'm doing the test because I want to determine if there's a foveal suppression scotoma. So if I go higher than that, I might miss one. Now, I agree, I can't do this test on every infant or even a young child. I don't have too much of a problem, but it does happen where I just can't get close enough. So I'm going to make an assumption with those kids. I'm going to use the Bruckner test and take a look at the red reflex, see if there's an asymmetry there. You know, a lot of those primary monofixators do have an anisometropia. If not, a small angle ET even will change the red reflex. Then I'm going to look for evidence of peripheral fusion by taking a 20 prism diopter single loose prism and put that up over the fixing eye and watch for the convergence to occur. It's a much easier movement to detect. And in fact, the easiest is when you take the prism away because the divergence just looks so odd to us. So it's much more obvious. So I would have gathered the information that we clearly have one eye that either has a higher refractive error than the fixing eye or has a microstrabismus, but I've got peripheral fusion. And because we know that suppression takes hold very quickly in the younger child, I make the assumption at that point that there is a foveal suppression scotoma until the child is old enough to perhaps do a different test or now use the 4-prism diopter base out.
Excellent. Thank you. Very fascinating. We could go on for another hour just on this subject alone. I mean, but I think we need to move on, correct?
Yeah.
Okay.
Yeah, that's right.
Thank you so much.
So I would like to invite our next speaker, Deniz Somer from Ankara, and she's going to speak about who will develop deviation in future refractive clues. Yes, Deniz.
Dear colleagues, good morning and good evening. High hyperopia in an orthotropic infant
Sorry, Deniz, we cannot see you.
Oh, sorry.
We cannot see you.
Yeah.
And could you make it full screen? We cannot see your appearance. Could you make your video on, please?
Yes, please. That's all right.
There we go.
And also full screen, please. Thank you.
Yes. Yes. High hyperopia in an orthotropic infant presents several clinic challenges. The clinician is faced with uncertainties about management, whether or not to prescribe spectacles, and if prescribed, how much hyperopia to correct. On one hand, prescribing spectacles might in theory prevent the development of infantile accommodative esotropia and or amblyopia. On the other hand, prescribing full hyperopic correction may hinder emmetropization. And if this concern is valid, prescribing partial correction may be a better approach, but how much? Concern is further compounded by the fact that not all high hyperopic infants develop esotropia. Possible explanation lies in differences in infant accommodation behavior. Accommodative behavior can predict which orthotropic high hyperopic infants can be observed without spectacles and are not at risk for developing esotropia, and which are at risk. To clarify the validity of this claim, we conducted a study, and these are the 2 papers published. Infants with high hyperopia, initially orthotropic but not fully accommodating, may develop esotropia later when they begin actively accommodating. On the contrary, if a high hyperopic infant remains orthotropic despite full accommodation, this may indicate strong fusional reserves, some mechanism to overcome the ESO drive, reducing the risk of esotropia. Perhaps a hypothetical infant with incomplete accommodation should be put in spectacles with just enough hyperopic correction to allow clear vision at near fixation. And another child, a hypothetical infant with full accommodation and stable alignment, may not require spectacles. Because dynamic retinoscopy is a simple office-based test of binocular accommodative ability, it was an ideal tool for testing this hypothesis. Our technique for dynamic retinoscopy was similar to that described by Guyton and Hunter, Professor Guyton, with whom I am now honored to be speaking at the same webinar. Infants with equal to or more than 5 diopters of hyperopia without anisometropia were followed without treatment or with partial hyperopic corrections in accordance with initial dynamic retinoscopy responses. 211 infants were assigned in trial. 146 infants constituted group 1, and they had neutral dynamic retinoscopy responses in either or both of the corresponding meridians in both eyes, so they were normal accommodators. In other words, the corresponding fixing meridians, typically the least hyperopic meridians, would have neutral responses, and these children that were normal accommodators were followed without spectacle corrections. Why? Because in theory, if an orthotropic infant with high hyperopia is accommodating fully, the baby is able to focus images onto the retina while maintaining binocular vision at near. So in theory, there is no need for partial or full hyperopic correction and no risk for developing esotropia. The remaining 65 infants constituted group 2. They manifested hyperopic with motion dynamic retinoscopy responses in both of the corresponding meridians in both eyes, so they were hypoaccommodators. These infants were put in spectacles, incorporating the minimum hyperopic correction needed to neutralize the with motion in the fixing meridians of the 2 eyes, that is, to change the HH response to NN response, neutral response. Because if an orthotropic infant with high hyperopia is simply not accommodating fully, he or she might be at risk for developing esotropia. If hyperopic, hypoaccommodation dynamic retinoscopy responses were observed, the examiner continued to introduce plus lenses in all 25 diopter steps in front of each eye in turn to determine the minimum hyperopic correction needed to neutralize the with motion in both eyes. The partial hyperopic correction that allowed for full binocular accommodative response was prescribed for full-time wear. In other words, at initial visit, there were hypoaccommodation responses. And after the initial visit, minimal partial hyperopic corrections now allowed for full binocular accommodative responses for near at follow-up visits. Follow-up was approximately 3 years. Group 1 consisted of infants that were normal accommodators and followed without spectacles. None of the infants in group 1 subsequently developed strabismus, and at 3 to 4 years, they had normal visual acuities for their age. Group 2 consisted of infants with high hyperopia that were hypoaccommodators. These were followed with minimal partial hyperopic corrections. And 34 of these 65 infants did not develop strabismus, which constituted group 2A. The remaining 31 of these 65 infants did develop strabismus, which constituted now group 2B. In case of initial deficient accommodation, there is almost 50% risk of esotropia. At least partial hyperopic correction that allows for full accommodative, binocular accommodative response for near fixation should be given. All children in group 1, which were normal accommodators, and group 2A, ortho-hypoaccommodators, with partial hyperopic corrections and no strabismus, had visual acuities that were normal for their age. Only hypoaccommodators who developed strabismus, that constituted group 2B, had lower visual acuities. Hyperopic decline in group 1 and group 2 were comparable to previous studies. Here are some comments on our findings. Binocular accommodative ability does not always seem to be a function of the level of hyperopia. An infant may accommodate efficiently with a hyperopic error of 7 diopters or may not be able to accommodate efficiently with a refractive error of 3.25 diopters. Initial dynamic retinoscopy response can predict which orthotropic hyperopic infants are not at risk for developing esotropia and observed without spectacles, and which are at risk. Infants who are orthotropic despite high hyperopia and show good accommodation, spectacles can be withheld. Furthermore, these infants have normal visual acuities at 3 to 4 years. If accommodation is insufficient by dynamic retinoscopy, there is almost 50% of esotropia, and at least partial hyperopic correction should be given. Some might argue that full hyperopic correction dispensed from the start would have reduced incidence of esotropia. Our rationale for partial correction was to preserve emmetropization. We do not believe that had we prescribed full hyperopic correction initially, that the incidence of accommodative esotropia would have been less. The amount of partial correction, according to dynamic retinoscopy, allowed for a clear formed image on the retina with the infant's natural accommodation for near fixation, so no additional accommodative effort was required. The reason for visual acuity in children who develop strabismus remains uncertain, but we do feel it was not due to incomplete hyperopic correction. Prescribed spectacles provided full accommodation and evidence that the images are focused onto the retina, so there was clear near focusing. Moreover, infants in group 1 who did not ever receive spectacles had normal visual acuity. There was no significant difference in emmetropization between children without strabismus and with strabismus, but both rates were higher than in previous studies. We speculated that increased emmetropization rates were likely due to preserved full accommodative ability in patients receiving partial hyperopic corrections according to dynamic retinoscopy. Based on data reported herein, the following conclusions seem justified. Dynamic retinoscopy appears to be a useful tool for deciding whether to provide an optical correction for an infant with high hyperopia. Only infants with accommodative insufficiency are candidates for strabismus. Hyperopic, orthotropic infants with normal accommodation do not develop esotropia, even if the lenses are not prescribed and have normal visual acuities after emmetropization period. Prescription of hyperopic correction according to the least amount needed to allow for near focusing may reduce strabismus, and amblyopia does not impede emmetropization and result in normal visual acuities after the emmetropization period. Dynamic retinoscopy by itself is not an effective screening tool. And even if binocular accommodative responses are normal, every child should go through a cycloplegic refractive evaluation to detect an amblyopiogenic refractive error. We'd like to invite you to the ESA TOA IPOSC meeting in June, which will be in Istanbul, and also to our life surgery symposium organized by Turkish Ophthalmological Association, where international online attendance will be free. Thank you very much.
Thanks, Deniz, for this very interesting and wonderful talk. And giving reference to your last announcement, I think you're all aware of the ESAT IPOSC meeting, but the live surgery symposium is going to start on 29th of May and going to last for 4 days. And international attendance, online attendance is free. And the first half day will be dedicated to strabismus surgery. So, I would like to ask a question. What I must say that your study also demonstrates that while correcting refractive errors especially in hyperopes, in moderate to higher hyperopes, the guideline tables are not they just give you some idea, but it is a method that you need to make an individual decision. So what do you think? Is it also possible to say that the ones who had embryogenic amount of hyperopia also have more tendency to develop esotropia? Could we go such an assumption after your results in your studies?
I think this is my opinion. Some infants are destined to be strabismics, like Professor Ingram's studies. I think that they will somewhat develop strabismus because they have lower visual acuities. You think that you have overcome the accommodative impulse with partial hyperopic spectacles, but still they develop strabismus. So I think something else is going on there that we cannot define now. This is my opinion, of course. It's a speculation only.
Thank you and I also, this had been another emphasis on how basic is to perform dynamic retinoscopy on the clinical practice of during our examination in children. And
There is an interesting.
Yeah, and there is a question. What about anisometropic hyperopic correction?
And we have deleted anisometropia, but this is our routine. If somebody is asking, we give prescription to anisometropic patients according to the cycloplegic figure with retinoscopy, and then we invite them again and check for the accommodation on the anisometropic eye, and if there is not good accommodation there, we give bifocals. So this is our approach, and I think everybody else's approach.
Okay, thank you. I think we need to skip to the last talk, and we have some more questions, but maybe we can discuss at the end, but it looks that we are not going to have some time. But what I would like to mention that for those questions that remained unresponded, and the speakers will try to text you afterwards. So our next speaker is, thanks Deniz, and our next speaker is Saurabh Jain from UK, and he's going to speak about prescription of glasses in a strabismic child. Yes, Saurabh.
Thank you very much, Seyhan and friends. It's great to be here, and we've heard some great talks today. It's been a great symposium. So I'm just going to try and bring things to a close by talking about some of the basic principles when you prescribe glasses for a strabismic child. So we'll start with a case. This is a 3-year-old boy who comes to my clinic. He's got a 4-month history of interning of the left eye, but there's another significant history. And when you examine him, you find the vision is down in each eye. He has a moderately large angle esotropia, left to alternating, 40 for near, 35 for distance, with full ocular motility. Everything else seems okay. And as we have heard previously, I think one of the most important thing would be to perform a retinoscopy. Now, in our practice, we use 1% cyclopentolate. and I use 2/3 of a meter. So this child is around +4, and he gets given the full prescription in the form of glasses to wear full time. So we see these children after about 3 months, and 3 months later, this is where we are. So his vision is now normal. He's orthophoric for near and distance, and he has regained his stereopsis. So this is a fully accommodative esotropia. So I'm going to talk a little bit about how and when to prescribe glasses in strabismic children, as the example I've just shown you, using these two as the main sources, the American Academy Preferred Practice Pattern and the Royal College of Ophthalmologists guidelines. Before we even start refracting, what drops should we use? Now, all children, as Professor Somer just explained, really need a cycloplegic refraction. So in my clinic, the rule is 1 after 1. So we use 1% cyclopentolate, maximum of twice within 30 minutes after the age of 1 year. Before the age of 1, most children get 0.5% cyclopentolate. In some children, especially the older ones, you can instill some proximetacaine beforehand to reassure them, but depends whether they'll allow you 2 drops or just 1 drop. We very rarely use atropine, but I know it's been used in some places, especially with lots of children with pigmented RADs. This is the method of examination. So on the whole, we like to use a semi-darkened room, not completely dark. The child sits either by themselves or in their mother's lap, and we use handheld lenses. We try and engage the child throughout. So we try and refract always on axis. If the eye is deviating, then it's a good idea, I feel, to occlude the other eye. So you're always on axis. We very rarely restrain the child, because if you restrain them, you don't really get very good results, I feel. And in some very anxious children, it helps to give them the drops at home so that they can be put in before they come to you and they are already dilated. For me, a game changer has been these refractive pet paddles, because they can very quickly help you bracket to get to an approximate refraction even in the most uncooperative child, and then you can go from there. We've heard about the dynamic retinoscopy method, so I won't really go into that, but just to say they are also very, very useful when evaluating these children. So going over now to strabismus, we talk first about esotropia, and which you can see in children both accommodative and non-accommodative forms, as well as convergence excess. Now, on the whole, for esotropes, you want to fully correct the hypermetropia, which means you correct the retinoscopy for the working distance only. You don't need to subtract for cycloplegia. You really need to ensure they're adequately cycloplegic, which means the pupils are not reactive and there's no change if you perform dynamic retinoscopy. We don't prefer autorefraction for any children, but specifically for these children. And the reasonable lower limit would be around +1.5. The greater the hypermetropia, probably the greater the role it is playing in the esotropia. If you suddenly see a child with a large amount of hypermetropia, you may need to step it up because they may not accept the full correction, or you might want to give them cycloplegia initially to help them accept the glasses. It can take up to 18 weeks for these glasses to work. And if you are unsure why the esotropia is persisting, it's a good idea to repeat the cycloplegic refraction before giving up. On the whole, children tend to accept hypermetropic glasses and isodeviation quite well. A lot of children will actually wake up and ask for them. It helps if they're accurately fitted and adjusted, and this may include things like head straps, which some children like, some children don't, flexible single-piece frames, as you can see here, with cable temples, with spring hinges, which just means the hinges can be distracted to quite a large amount, and the FDA now mandates impact-resistant lenses for safety. A very specific form of esotropia is the convergence excess esotropia, which are essentially children who has esotropia that's greater for near than distance fixation of about 8 to 10 prism diopters. So they are orthophoric or well-controlled esophoric for distance, but have esotropia for near. There's a fantastic paper by Professor Arnoldi, which looked at 77 of these patients. And what was really interesting was only 50%, only about half of them had a high AC by A ratio. So not all of these kids have a high AC by A ratio. And even of those, only 22 of the 39 actually responded to a +3 override in clinic, which means less than 1/3 of the of these patients with convergence excess esotropia responded to a bifocal. So bifocals, especially those bisecting the pupils, are really helpful for a selected group of patients with high AC by A ratio. But most importantly, they have to demonstrate in the clinic, then when you add the +3 add, it makes a difference. Not only does it make a difference, it should really make them orthophoric for near and really should be able to demonstrate stereopsis. So what do you give them? Well, for the distance, the full cycloplegic correction, and for the near, the smallest amount of add, which controls the near deviation. They have to be the executive type, which means they bisect the pupil, and a flap top design tends to work best. So this is the kind of glass you don't want to see, these small D segments that are lower, but they are good for adults who want to use them to read, but not really for children. You can use progressive bifocals, but they're really restricted in children by cost, the importance of accurate centering, and mostly them being an adult design, which means the plus is too far below the primary position. The whole point of bifocal glasses is to aim to develop fusional amplitudes. So if for a year you have stable alignment and fusion with good amplitudes, then you can slowly start to reduce the strength of the bifocals. You do this by putting up a -0.5 or a -1 when they come to clinic, and if they maintain the alignment, you can slowly remove the bifocals or taper them down. So what is the success rate? How many children can you get out of bifocals and develop good fusion? Again, depends on the author. So Carl's papers had said only about 20%, but Arjen Ludwig and Co showed about 60%. I think it really depends on the group that you are treating, as Carl showed very nicely, because only about half of them actually even needed or were even suitable for bifocals. So the majority of patients with convergence excess ET are not even eligible for bifocals. So do remember that they may be considered with those with a high AC by ratio who respond to the addition of a near add so that they can achieve some degree of binocularity. For most of us, we see these glasses as a holding procedure until we can do something a bit more long-term for them. The only study I could find that looked at bifocal versus unifocals found actually there was no difference in sensory result. The only in both of them, they had about a 7% failure rate. So quickly going on to exotropia, there are various kinds of exotropia you see in children. On the whole, this is easier. They're either high hyperopic or low to moderate myopic. And on the whole, you want to correct the refractive error in these children. Myopes definitely need correction. Even small amounts of myopia, if corrected, have a significant impact on the exotropia. If they have mild to moderate hyperopia and reasonable vision, you may try not to correct them because you definitely will make the exotropia worse. But if the hyperopia correction is larger and it does improve their vision, you should give them the least amount of hyperopia you can to correct the vision as much as possible. If you are going to operate on the children, then absolutely need to fully correct them to judge the correct angle of deviation. There was a trend a few years ago of stimulating accommodative convergence in these children, which means you improve their fusional control by increasing their myopic correction or reducing the hyperopic correction, or even giving a myopic correction to emmetropes up to -2.5 diopters. Now, in some kids, this was not tolerated, but a more pertinent point was even in the children that tolerated it, we found this was associated with a greater myopic shift that persisted after treatment was discontinued, whereas that improved control did not. So I think this has pretty much fallen by the wayside, and most of us will not over-minus children anymore. So just to summarize, prescription of glasses can aid management of strabismus in children. When we cycloplege them, we use 1% cyclopentolate over 1 year. Esotropes, full correction of hypermetropia. Exotropes, full correction of myopia, as little plus as possible. About a third of convergence excess ET patients benefit from bifocals. Thank you very much for your attention.
Thank you, Saurabh, for this excellent talk. So, well, we have some questions for you, and actually, you have mentioned this during your talk, but it is asked that whether you prefer the autorefractors instead of refraction and so on. So You have actually mentioned your choice, but could you give us your reasons for that?
That's a good question. So I looked at the evidence base. So in my clinic, we almost never use an autorefractor in children. So when we look at the makes of autorefractor that work, where there was a meta-analysis that showed of all the autorefractors in the market, the Plus Optics probably is the best. However, all autorefractors tend to overestimate myopia and underestimate anisometropia and and hypermetropia. And there's a recent paper from the Tasmanian eye test study, and they recommended cycloplegic refraction for up to 18 years of age. So on the whole, if you can, do a cycloret.
Yeah, that's I fully agree with you. So I must say that the real autorefractors are all produced for a person who have a very perfect look. And also they almost always underestimate hypermetropia, especially in infants. So, and another question is, let's say, when I see a child who has 15 something remaining ESO with a high hyperop in a small child, I mostly try a +1 overcorrection, and amazingly, some of those tolerate it so well. Well, these are actually the ones that, even though with the retinoscopy and full cycloplegic refraction and so on, we miss some parts. And what do you think on that? Do you agree on that? And do you have a similar approach?
Yeah, absolutely. So I said that in my lecture. Sometimes you give them all the plus you can and they still ET. So you can, I think we sometimes do miss a bit of plus. And I think if they can accept it, the common parlance is to push the plus. You give them as much plus as you can, and you want to give them as good an alignment. I find over plussing doesn't tend to work because it blurs their vision and they don't like it. But we give them as much plus as we possibly can to get them as straight as possible.
And there is one more question in Q&A. Do you use 2% cycloplegia for dark irises? Because even though, let's say in our population, we almost always use 3 times. And even though it is not adequate in many ones with dark irises. And what is your approach? And this was the question about the high percentage.
So we have a very mixed population in London. So we really are the whole world in one city. On the whole, we never use anything stronger than 1% cyclo and never more than twice, because we've had a few kids have hallucinations following more. I think with time, I think 2% cyclopentolate or 1% cyclopentolate is enough. And the other thing that we feel helps is putting them in a dark room. So that is, and it sort of calms the child down as well. So we put the 1% cyclo, we have a dark room that they can use. And I think on the whole with time, that sort of works. And sometimes we just go and refract them in that room, not giving them time to come out in the light again. And that sort of works for us.
And there's one more question in Q&A as what do you do in those who had epilepsy? Do you have some specific methods or any other method to examine those children?
So not really. I mean, we don't really change a protocol for epilepsy. We change it for things like cardiac disease. If, for example, phenylephrine is contraindicated, but for epilepsy, we tend not to. I suspect the question is linked to epilepsy triggered by light, but we haven't had any issues so far. Fingers crossed.
And one more question. In those who had large intermittent exotropia, do you still give them reduced hyperopia, or you just go on surgery, or do you, let's say, do you prescribe, do you consider to increase the amount of correction if you are planning to go on surgery for hyperops?
Sure. I think the key point of planning any surgery in exotropia is control. Okay. And to look at the control, if you're planning a surgery, you have to see the appropriate refractive correction. So you have to look at them with the refractive correction, the vision as good as you can get it. And that's when you see the control. And the control is less. So you can use the Newcastle control score, for example, is than 3, then we would operate. But absolutely, we're going to operate. We want to give them the full refractive correction to uncover the full amount of deviation so we can plan accordingly.
Yeah, well, I think, Alex, there are still lots of questions, but
There are.
very brief answer, please. Do you ever use 1% atropine? This is in the Q&A box.
Almost
Yes or no?
never. Almost never.
Never. Okay.
And just a
So,
brief,
Alex, do you have any additional comments
just
or
a very brief
questions?
comment. Very brief comment. I know your comments about over-minusing, it remains controversial. And despite the results of the PEDIC study that, found progressive myopic shift with over-minusing, it's still kind of alive and well, in clinics throughout the United States. We hear about it all the time. We see patients for second opinions who are, so it's still being done with or without evidence. I'm not necessarily a fan, but I'm just sort of pointing it out. I wonder what other people's experience are around the globe.
Yeah, that's interesting. Maybe because we're a smaller country and we have a very strong orthoptic presence within the United Kingdom, and so I think things disseminate a bit more quickly, and maybe because it's a more nationalized system. So so we had a few webinars very early on when the PEDIC study came out, and we were seeing similar results, and since then it's pretty much, from what I know, fallen by the wayside. I haven't seen any evidence.
Good to know. Thank you. Great talk.
Thank you. So, well, unfortunately, thank you, Saurabh, for this was an excellent presentation. And unfortunately, we are already out of time. And we have 15 minutes actually out of time. So we're not going to have any discussion at the end. But I'd like to repeat that for those questions who could not be asked during the this webinar, the speakers will answer them by your emails and so on. And I would like to thank all the speakers, of course, firstly, our dear President Tamara, and all the speakers for their excellent talks, and for all the participants for joining us and for asking lots of very interesting and very motivating questions. And thank you very much. And I would like to give the closing word to dear Alex.
Oh, thank you, Dr. Özkan. A couple things did come up in the chat, and something for IPOSC to consider will be whether you can get credit for this continuing education credit somewhere down the road. We'll discuss it, things like that, especially if the AACO is involved again, because there was a lot of questions from our attendees about getting credit. But I always want to say thank you, reiterate what she said. Thank you to all of our gifted and talented speakers for sharing their years and years of experience and talent with us. And thank you to all of you across the globe for taking time out of your days to be with us. That's all I have.
Thank you.